Hi guys, I think only few have joined. So we'll just wait for another 5 minutes and see if anyone are joining. Otherwise, we can start, right? So we'll just wait for 5 minutes. Hi guys, am I audible?
Yes.
Yes, sir.
Okay, okay, thank you. Fine. I just want to cover a few topics before getting into the interview questions. Just give me a minute. So you won't get any questions on those topics which I'm going to cover, but for basic coding, like basic surgery coding, I'll just give you an outlook of that, okay? So can you guys just tell me what is the trimester, the weeks of gestation?
Each time.
Yeah, I just want to know the weeks, like from which week to which week does the first trimester covers? Okay. 20, 28. Okay. 39 or 40, right? Yes. So that is your trimester. So from 1 to 13 or 14 weeks covers for the first trimester. And from the 14 to your 28 weeks covers your second trimester. And from the 28 or 29 till the term. Okay, so till your 39 or 40 depends upon each individual uh, and the health of the baby to, to deliver, to get out of the womb. So this covers the third trimester. Okay, right. So all these are very necessary in order for you to code for abortions as well as for the delivery. Okay. So we have two types of delivery, right? So we have the vaginal delivery and as well as the cesarean delivery. So these two have its own, pros and cons, which we all know. So coding delivery charts is quite tricky, and at the same time, you need to be like, you just can't be playful while coding for the delivery charts because there are a lot of ICDs you need to code in, and there are a lot of CPTs. Like the CPTs are based upon the package they're taking. For sometimes, if the patient might be in, the patient comes in, he gets her. I mean, she gets her post delivery treatments and plans from the same doctor, and also during her during her delivery, she gets the delivery, the treatment from the surgeon, the same surgeon, and maybe she might just, get delivered at the same hospital and come back and might get a post-delivery treatment from other hospitals. So according to that, we have certain CPTs. Okay, so that is why I, just said that it is kind of tricky. So, so we need to know about the antepartum care. We need to know about the postpartum care and the intrapartum care. So, what is the antepartum care?
During pregnancy.
Okay. What is intrapartum?
Same pregnancy during period stage.
During the delivery. During delivery, yes, correct. During delivery is what you mean by intrapartum. Okay, and what is postpartum?
After six
What's
After
the
weeks,
delivery.
After the
Same.
delivery.
after 6 weeks? After 6 weeks, what? Nothing. Delivery
puerperium period,
till
Delivery
actually.
6
after.
weeks. Yeah.
After
So
the
once,
cesarean period.
yeah, so once a patient is, delivering a baby, until 6 weeks, it is considered as postpartum. Until that, her package, whatever she's, getting from the hospital, will be included in that global delivery package. Okay. But after 6 weeks of her postpartum, if she's coming for any other services, it will be billed separately. It won't be included into the delivery package. Okay. So you can see here for the vaginal delivery, we have CPTs 59400, 59409, and 59410. So this is for, it's a package, guys. Okay, so this is a package for vaginal delivery. Okay, so as I told you, the patient will come in for a, so, most of the time, all the women over there, they get comfortable with one gynecologist, right? Why? Because they will, take all the care and everything during their pregnancy, and of course, they will fix the date, okay, the delivery date over there in the same hospital by the same for the with the same person. So if that is the case, if that is the scenario, if the patient is, getting all the antepartum care, and also if she's getting a vaginal delivery fixed, okay, and also the postpartum care. So this is what we call as routine obstetric care. Okay, it's a whole package. So if that is the case, then you can quote 59400. Okay. Now, if the patient comes in only for delivery, vaginal delivery, okay, just vaginal delivery, she might have not got any antepartum care or any postpartum care with that person, with that surgeon or an gynecologist, but she's only getting a vaginal delivery from that particular hospital. If that is the case, then your CPT should be 59409. Okay. Now, sometimes there is like, some part of some group of women who will take antepartum care from one hospital, and she might have, like, she will go to her home, right, for the delivery. So once she goes to her home, she will change her hospital, like she might change her doctor, gynecologist, and there she might get her vaginal delivery and her postpartum care. If that is the case, she's taking that particular package only, the delivery and as well as the postpartum care. If that is the case, then you should be coding 59410. Why? Because she will take the vaginal delivery along with the postpartum care. So that is one package. Okay, so this is for routine obstetric care for vaginal delivery. Okay, so these are all they won't ask you for any interviews and all. So once you see, this is again very rare, guys. I'll tell you. Um, same day surgery doesn't involve delivery charts. Okay, but if you get into an company where this, they wanted some specialized coders for OB-GYN. If that is the case, then this is very, very helpful for you. If not, you can, for a knowledge, you can understand this. But as I told you, in all the companies, you won't have OB-GYN, but you will be seeing cases on abortion. All those are, day-to-day scenarios you can see. But this delivery thing and all are, coded by some OB-GYN coders, special OB-GYN coders, which you cannot, like, see in all companies. Okay, so basically, same day surgery is nothing but you will code from 1 to 6 series, but most of the series won't be involved. Like, for example, 3 series. 3 series, again, I taught you pacemaker defibrillator, but you won't be seeing that every day. they will have a set of coders to code that particular charts. Okay, I don't know if you guys are familiar about IVR coding, radiology coding, gastroenterologist coding, um, what else? Yeah, plastic coding, plastic surgery coding. So now they have segregated all, all these separately, into separate facilities, and they're seeking coders for that. But for same day surgery, you can see frequent, scenarios in hernia, umbilical surgery, and mastectomies and arthroplasty. Okay, fractures. So all these scenarios you will be, coming across. But delivery or a pacemaker defibrillator or bronchoscopy and all, it's kind of like you might just see two charts maybe per month. Okay, so again, it's a rare thing. Okay, so it's totally dependent on your client which you want to work. Okay. Right. So now coming for the cesarean delivery. So we have CPTs again. So this is for routine obstetric care for cesarean delivery. So like how we saw for vaginal delivery, for cesarean delivery, again the package routine obstetric care including antepartum, cesarean, I mean the antepartum, the delivery and the postpartum care. If the woman is getting a treatment, a full package from the same hospital from day one to day, whatsoever, maybe ninth month or 10th month she's getting delivered, till day one, till her 10th month, till her delivery or till her postpartum care, if she's taking the package from the same hospital, from the same provider, then your CPT is 59510 for cesarean delivery. Okay. And if it is only for delivery she's coming, then it is 59514. And if she's choosing delivery along with postpartum care, then you should be coding 59515. Right. So this is the case. Now, while you're coding the ICDs for delivery charts, the first thing you need to check for is that the age of the patient, whether she is below 35 or above 35. Okay. So you have certain, codes, ICD codes for below 35, supervision for encounter for delivery below 35. But if she's above 35, you need to mention that. Why? Because above 35, mostly they term it as complicated delivery. So for the age, right? So if it is above 35, then you should be coding your PDX as for the encounter for supervision of pregnancy above 35 years of age. Okay, so there will be an ICD for that. Then you should check for the outcome of the delivery. That is very important. If the baby is born alive, okay, the baby is alive, or if the baby is born dead, or if it is a stillbirth, like whatever the outcome of delivery is, you should be coding that at the end of the ICDs. Like you need to sequence it at the end. Okay. Then if there is any complications, whether it is any fetal complications or mother complications, whether it is gestational hypertension or diabetic, whatever the consequences are, or whatever the complication the mother and the baby has, you need to code it. Right? For obstetrics and delivery, your ICDs start from O series. So you should code all the ICDs which is available in your OP chart. But your PDX should be encounter for supervision for delivery. And definitely you should look for the age. And if it is below 18, you have a very unique ICD for that. Okay, supervision for encounter for delivery below 18 years of age. Like it is considered as, like, again, it is complicated, right? Why? Because the age is below 18 years. For that, you should be coding that as your PDX first, and then you can sequence the other complications if there is any. Okay, so whenever you're coding for delivery charts, it's a very sensitive chart. Okay, so because there are a lot of, it's kind of high dollar charts, and you have to code it very cautiously. Okay, you cannot miss any ICDs, right? Because every ICDs in the O series are like having high dollars. Okay, and as well as the CPTs too. So because I've seen people, like lethargic errors I have seen. Why? Because They know it is a female child, but still they code it for like, they missed to code. Sometimes for male child, they will code for female. That is how I've seen a lot of errors. So make sure that if you come across any delivery charts, make sure to code your PDX correctly so that it gets linked to the delivery to the treatment they have provided to the patient. Okay, whenever you're coding for the PDX, whether it is for maternity or delivery or whatsoever it is, make sure that it is linked to the CPT. Then only it won't get denied. Otherwise, denial will happen, it will come back. Okay, so PDX, primary diagnosis is very important, guys. Even if you miss one or two secondary diagnosis, doesn't matter, but primary diagnosis is very, very important. And always code the status post. If the patient is having, absence of one kidney or absence of any digestive parts or absence of one breast, whatever it is, you need to give the status post of that particular absence. It comes under Z series, so you have to sequence it at the last. Okay, that is very important. And whenever there is any long-term use of anticoagulants, so we can all capture all these things. It is very good. And always try to code the combo code. Okay, uh, like for example, hypertension, kidney failure, heart failure. All these have combo codes, right? So you have to keenly see that and code it accordingly. That is one thing in your chart. Um, and the modifiers, guys. Never miss to, you know, code the modifiers, whether it is RTLT or foot modifiers or toe modifiers or any numerical modifiers like the 52 or 51. 51 we don't use it mostly. Again, it depends upon the client. Okay, it's kind of a sensitive modifier, so they don't use it. But 59, you probably can see a lot of 59. When it is non-Medicare, you will use 59 modifier. When it is Medicare, you will use XU modifier, right? That is one thing you need to know. So all these are like some checkpoints when you're going to code for the OP chart. Okay, the surgery OP chart. Now coming to the 6 series, I just want to show you, like, I know you guys know mm, the ear procedures, right? We have some ear procedures here. So in 6 series, you won't get any questions, any interview questions, no. The interview questions which you will get is from 1 series, 2 series, 4 series, 5 series. Why? Because those are vast, okay? And there are a lot of guidelines they can ask and dig, okay? So,
Hello,
but
Sonia. Sonia,
yeah,
ha-
yes, who is this?
please repeat this series. Please repeat this series.
Okay, okay. Yeah, Vrishali, sure. So, from 1 series, 2 series, 3 series, most probably, not everything, but still, I'll tell you the questions. And 4 series, yes, the guidelines, the colonoscopy guidelines, all these they will dig and ask you, okay. And 5 series, they will ask you regarding the types of treatments used for breaking the or destroying the kidney stones. That is what they'll use. They'll ask mostly, and they might ask you if you have any prior experience in coding with delivery charts, or they might ask you if you know to code uh, the OB-GYN and all. So they might ask you, like, it's a kind of yes or no. Even if you say yes, they won't ask any, they won't dig it because it's straightforward. Okay, so they won't dig it. And in 6 series, they might ask you the anatomy of ear, anatomy of eyes, they can ask you. And they can ask you what is cataract. So, what is cataract, guys? What is cataract? Why people do cataract surgery?
Routing of
Especially
lens.
clouding of lens, right? So the lens will become like clouded. So what happens? The patient, mostly cataract is affected in older people, right? People, more than 45, 50 age. And also it has a link with diabetes mellitus. So sometimes diabetes mellitus can be a factor causing a cataract. And so mostly people with cataract, they gradually develop vision loss. So before that, what they'll try to do is they will do the cataract surgery, right? So we have two CPTs for cataract surgery. So it is very simple. So there are points which you need to be knowing about. So whenever you're coding for cataract, so let me just show you. So we have 669. Yeah. So 66982 and 66984. So these two CPTs you will be getting frequently in same day surgery. Okay. So in 66982, this is for the the complex kind of procedure. So if they are doing any complex procedure, cataract, just wait a second, guys. So if they are performing any complex procedure in cataract, so before that, I'll just teach you what is simple cataract. Right. So simple cataract only takes 10 minutes. So they will just, cut open the lens, take away that, they'll just aspirate that clouding, that, whitish discoloration from the lens, and they'll replace the lens with a prosthesis. So that lens will be quite expensive. It depends upon the quality. Um, that lens can cost like 1 lakh, 2 lakh. Again, it depends upon the quality. So they will replace that with the prosthetic lens. Okay, they'll remove the the natural lens and they'll replace it with prosthetic lens, so that the patient will have an improvised vision without glasses. Okay, so this procedure without any mechanical technique or anything. Okay, they will do it within 10 minutes. So if that is the case, you can code 66984 as simple. But if they are doing any you know I mean, if they are doing a procedure, a cataract procedure, and if they required any devices which is generally not used in a cataract surgery, I mean, okay, but if they use it during the cataract surgery, devices such as capsular tension rings. So these rings are used to just support the lens. Why? Because the lens zonules, this lens area, zonules will see. The lens zonule will become weak. Sometimes, not in every patient, but at times. If that is the case, they will fix a CTS, capsular tension ring, to support the lens. If that is the case, you can have to code it as complex 66982. Again, the next device they can fix it is the myelurine ring. Okay, myelin, you can note it down. Myelurine ring. These and all you won't see here in the CPT book. Okay, so these are all coding tips which I have seen like day to day. So myelurine ring, if they are using myelurine ring, it's again a kind of a ring which supports the lens. Okay, supports the iris. That is the scenario. Then you should be coding it as complex. And if they are using an dye, okay, blue dye, methylene blue dye, okay, trypton dye. Okay, so if these are the dye terms which they use, you can consider it as complex procedure. Why? Because these and all devices and dyes and all, they won't use it in a normal routine cataract. But if they are using it, then it is not a routine cataract surgery. It is a complex one. So what are the terms you will search for while you're coding cataract surgery?
Myelin ring,
Okay.
methylene dye,
Okay. Capsular tension rings. Okay. And also you can see iris expansion devices. Yeah. So expand if they are using any device to expand the iris. Okay, not to focus the iris, but to expand the iris. If that is the case, then you can code 66982. Or if they are doing any suture to support the lens. As I told you, sometimes lens can become weak. And to place a lens properly without movement, sometimes it can, relapse or something. So if that is the case, if they're doing any suture around the lens, IOL, okay, intraocular lens, then you can code it as complex. But sometimes you can see they might use only dye. Okay, they'll just use some tryptan dye, and most of the time they will use dye. Okay, to see if there is any abnormalities or anything. If that is the case, only dye is being termed in the documentation, then you should not code it as complex. You can code it as simple. But if they have mentioned about dye or any, support device or any, myelin ring, then definitely you can code it for complex. Okay, so this is one scenario they will ask in the interview. When will you code it as complex? So at that time you can say all these points. Okay. So this is one thing they'll ask, and the other thing is regarding ear. Yeah, ear procedures mostly you will get it as this wax serum and removal. That's all you'll get it. Same, simple procedures you'll get in the 6 series. And they can ask you what is the anatomical structure, what is the anatomical structure of eye. So you can just Google it and can learn about it. Like simply you don't have to say everything, but simply you can see what are the important structures like lens, cornea, iris, vitreous chamber, like all these things you can say, conjunctiva, and optic nerve, because optic nerve is very important. It supplies blood to the eye, right? That is very important. And the retina. So all these things you can learn. Okay. At the same time, even they will ask regarding ear. Yeah. So for ear, you can say the external part of ear. You have the pinna, you have the helix, right? Then you have the eardrum over here. This is the middle ear, right? Then you can say the malleus incus and stapes. These are the bones of the ear. So and then you can say the cochlea over here, which is very important. Okay, the cochlear nerve which supplies to the ears. So these are some important eardrum. So they'll ask you what are the parts of your ear. So you can say outer ear, middle ear, inner ear. Okay, so outer ear has this helix, pinna, earlobe, and also the middle ear has the tympanic membrane and all, the ear canal. Then you can say about the inner ear, which has eardrum or TM, tympanic membrane. and it also has the smallest bone, staphylos, incus, and malleus. So all these things, like you can say in a proper uh, line, okay, proper statement, a proper context. You have to say, explain it, okay. So that is one thing. So please try to um, to even learn about the what to say, the anatomy, because anatomy they will ask you sometimes. Okay, just give me a minute, guys. I need to open one. Yes, tell me. It is not saved. Yeah, tell me, who is it? Someone was asking something. Can you please repeat? Yeah, yeah, they will ask anything. Yeah, stapes, yeah. Yeah, longest one, what? Tell me. What is a thigh bone? Right, femur. Is this not getting? Just wait a second, guys. Okay, is it visible?
Yes, sir.
Okay, so starting from this series one, so as I told you, to which company you go or anything doesn't matter, but the questions will mostly be the same. Okay, so biopsy. What is biopsy and what are the types of biopsy? So that is very important. So you should know what is biopsy. You should know to tell it in a you should like define it. You cannot say just like biopsy is this is what they do. No. So you have to like convey it in a very good way. Like you have to say biopsy is a medical procedure in which the surgeon removes tissues and send it for histopathological examination. So I have just just wrote it, I mean, typed it in my own words. So I'll just I'll send this copy to you too. So so you need to say like biopsy is a medical procedure in which, so you need to you know make an impression that yes, like I told you, right? Interview is not like they'll ask you and just for a single word, like you cannot answer it in a single word. Like, you have to express it, right? So you have to use some terms, you have to use some, grammatical terms, put it in a sentence and say it. And you don't have to hurry up to answer, but you can just, once the interviewer is asking you something, you can pause for a second or two, not more than that. Like you cannot take 1 minute or 2 minutes, they will skip to another question. No, just pause it in a very in a good way and um prepare what to say. Okay, so the only thing is that before attending an interviews, you need to prepare, right? So you have to prepare with all the materials and the questions. You have to prepare it like once and twice and thrice, so that you yourself have a confidence that yes, you can attend the interview, right? So I have taken some of the common surgery questions which is been asked in most of the interviews in Chennai. So, and I think most probably these are the why, because these are the procedures you will go through, okay, in your surgery coding for same day. Okay, beyond this, no, they won't ask you anything for sure. Okay, so they'll just ask you some 5 to 10 questions to just check on you. And if you keep on answering all the questions in a very good way, in full sentence, Okay, then they will just get impressed. And again, I'm telling you, you cannot answer it in one single word. You have to explain it. Explanation matters. Okay, even if you go for next level too. So now you might be in some people might be a code, coder, some might be an auditor, some might be into, other things like, TL or anything. So if you want to get into a next position, you always have to explain. You have to take some time, explain it. Okay, so that's how you can impress the interview. So now coming back to the questions, biopsy and its type. So I have given you some, I haven't, typed everything here, but just for tips, you need to build this, you need to build your, you know, what to say, perspective from this tips which I've given. Okay, so you can add this and see, I have just typed here that what is biopsy. I have typed what are the types of biopsy, and then you need to explain each biopsy, how they perform. Okay, so for example, biopsy is a medical procedure in which the surgeon removes tissues and send it for histopathological examination. So the types of biopsies are incisional, excisional, punch, core needle, fine needle, and tangial. Incisional biopsy is where the provider uses a sharp blade to remove full thickness lesion from the subcutaneous. So you should keep on saying that you should never allow the interview to abrupt you or interrupt you and ask you something else. So that's how you have to like overpower your the person who is taking an interview, right? So the next question will be kind of he will think that yes, you know everything and that's how you're explaining everything. So he'll be a little scared to ask you questions. This is true actually. I've seen so many in so many interviews, like if the opposite person who is getting interviewed is very strong, the one who is asking the interview, they will feel little scared to ask too many questions. Okay, so try to overpower your interviewer in a good way, in a kind way. Okay, but not to show any attitude or nothing, but in a kind way. The way is nothing but to express and explain all the questions in detail. Okay, so as I told you, incisional, excisional, punch, core needle, FNA, tangent. So all these you need to explain, at least two lines you need to explain. Okay. Then this is one question. The second question is types of repair, or they can ask you what is the types of closure. So you should say that repair of wounds are classified into simple, intermediate, complex. So you should say what is simple, what is intermediate, and what is complex. Okay, so here you can see simple is when a wound requires only one layer of closure. And layered closure, or we call it as intermediate, requires one or more closure involving deeper subcutaneous structures, okay, which includes limited undermining and single layer. So there is one mistake away. Okay, and single layer. This is one point. The next point is that single layer with heavily contaminated wounds also can be coded as layered closure. Why? Because heavily contaminated wounds require extensive cleaning. So you need to understand, you need to say all these points which are very, very, very important. Okay. Right. Now complex. Okay, so in addition to simple and intermediate repair, complex repair requires at least one of the following. So there should be an exposure of bone, cartilage, or tendon. Also if there is an extensive undermining which they have mentioned, then again you can call it as extensive complex repair or complex closure. Okay, so these are the guidelines. So when multiple wounds are repaired, so for example, there might be multiple wounds, and if they are repaired, you can add together the length of the wounds, which comes under same code descriptor. Okay, if for example, if wound is in the arm, leg, and hand, so these three will come under same code descriptor. So in that case, you can code the length of the wounds and just report one code. When more than one classification of wounds have been repaired, code the complicated as primary procedure followed by the least complicated with 15 modifiers. So what they're trying to tell you is that if it is more than one classification, for example, one repair might be done as complex, one repair might be done as simple. So in that case, you have to code the complicated. That is, the complex repair is the most complicated, followed by the least complicated, which is simple repair with 59 modifier. Okay, so these are the guidelines. So in one series, you have a lot of guidelines, right? You have a lot of guidelines. And two series, you have like not like one series, but still you have it. In three series, you have no guidelines. You don't have much guidelines in three series. But in four series, you have guidelines, colonoscopy guidelines you have, right? So that is very important. And I think only colonoscopy has the like most of the guidelines. And in five series, again, you don't have any guidelines, but you have some particular what to say, procedures which they can ask. Okay, and that is one thing. They will also ask, apart from all these things, they will also ask you the modifiers. What is 53? What is 52? What is 73? What are the difference between 73 and 74? Okay, what is the difference between 52 and 53? So when will you give 53? When will you give 73? So this is how they will, they'll twist the questions they ask you. So like, I'll tell you, I'll just moving forward, I'll tell you how. But just I'm telling you the scenario. This is how they'll ask you. And they'll ask you what is NCC edit. Okay, so all these things they can ask you. And as I told you, anatomy. So a person like 8 to 10 questions they can ask you easily. Easily they can ask you. Okay, right. Now coming to the excision guidelines. So codes are determined by measuring the greatest diameter. So as I told you, right, the one thing you guys have to remember is that in excision you cannot add the lesion together and code. That is very important. I remember you guys were, confused whether to add, and you guys used to like add the lesion, excision lesions, and give the answer. No, whenever you're coding for excision, you have to code each lesion excised separately. Okay, that here. Okay, that's very important, guys. Mostly 19% people do blunder in this, I've seen. Okay, so even if there is an lesion which has been excised from your arm, okay, there are two lesions which has been excised from your arm. One is 1.2 centimeter, other is 1.5 centimeter. Both you have to code separately. Even if it is of same CPT, doesn't matter. You have to code each separately with 15 modifier. 15 modifier is to show that it is of separate incision. Okay, so that is very necessary in excision. This is one point you should never forget. Okay, and while coding excision, you need to measure the greatest diameter. For example, if a lesion is 4 into 5 centimeter, you have to take it as 5 centimeter because that is the greatest diameter. Okay, then when an excision has been done and adjacent tissue transfer, we call it as ATT in short, has been reported together, you only have to code the ATT only. You cannot code excision. This is another guideline. Okay, so for example, that they have done excision, they have excised the lesion, and now to cover that defect which has been caused by the excision, they will do an adjacent tissue transfer. So in that case, you will only report the adjacent tissue transfer. That's all. Okay. The next thing is whenever whenever a lesion is excised, if the closure is simple, it is always inclusive. You don't have to code it separately. But if it is layered closure or complex closure, you need to code it separately. So this is applicable for 10,000 series only. But if the excision is from 20,000, say that is from musculoskeletal, then simple closure and intimate closure both are inclusive and you have to code the complex closure separately. Okay, so you can see here. In 20,000 series, simple and intermediate closure are inherited to the excision codes, but code complex closure separately. And in both 10,000, 20,000, if they are doing some reconstructive procedure, for example, graft or what to say, flap, if that is what they are doing, those procedures you have to definitely code it separately. Okay, so that is one thing you need to understand. And coding adjacent tissue transfer. So whenever you're coding, as I told you, when you're reporting ATT and excision, you always have to code the ATT only. Okay. Okay. So whenever ATT is being done, the code selection is based upon the primary defect. So the primary defect, it is being caused from the excision, right? And the secondary defect is caused from the flap design. So they will take a flap, right, to cover that defect. So taking a flap is also making a defect, right? So to perform ATT, these two has to be, um, you know, added or measured together. We can say some. Mostly we, multiply it actually into square centimeter. Okay, for example, 5 into 3. If that is the, square centimeter they have given, you have to, code it as 15 square centimeter. Now, accordingly, you have to select the CPT for adjacent tissue transfer. Okay, that is one thing you need to understand. They'll give you the measurement itself. Sometimes the measurement pattern will be like 15 to 3 or 10 into 3, so that is how they mention. So in that case you have to multiply for 880. Okay, and the other terms which they use to denote ATT is Z plus T, VY plus T, rotational flap, rhomboid flap. Okay, so all these are other terms which you can see in the chart. Okay, they will use it. They won't directly say as ATT. They will use it as local advancement flap. They will use it as rhomboid flap. So these are the terms they will use. Okay. Then coming to debridement. So we have a procedure. No, we know what is debridement procedure to remove the dead and infected tissue, right? That is one thing. So, but while reporting debridement, we need to know how to code it. So when one single wound has multiple depth, okay. So for example, if they have debrided the subcutaneous layer and also the muscle layer and also the bone layer. So in that case, you have to report the deepest depth. So here our deepest depth is the bone. Okay, just give me a second, guys. Okay, so deepest depth you need to report if the single wound has multiple depth. Now, then multiple depth of same, one second, yeah. So when multiple wounds of same depth, for example, there are 2, 3 wounds in other so there are 2, 3 wounds from different. Just give me a second, guys. Just 2 minutes. Yeah. So if the multiple wounds of say, this same depth, like for example, if there is a wound in the arm, there is a wound in the leg. Okay, if there is a wound in the fingers or the hands, but if it is of same depth. Okay, so most of the all these wounds, if they have debrided till the muscle layer, so that is what we mean by same depth, right? In that case, you can add the total square centimeter and just report one code. Okay. Now, if the multiple wounds, like two to three wounds they have is of different depth. So one wound is they have debrided till bone, other wound they have debrided till the subcutaneous tissue, and the third wound they have debrided in the till the facial level or the muscle level. So this means that these multiple wounds have different depth. So in that case, you have to report the deepest depth first, and followed by the add-on codes with 59 modifier. Like for example, so first the deepest depth is nothing but the bone. So deepest depth you have to code for bone for the wound which has they have debrided till the bone. Then the second layer like muscle, if they have debrided any wound till muscle layer, that you have to code second. And third you have to code the in the least what to say least depth, that is the subcutaneous to the subcutaneous level. That is the case, you have to code it as third. Okay, with 15 modifier to show that there are multiple wounds which has been debrided. Okay. Then they can ask you what is simple and complicated IND. So we know what is simple. Simple means they'll just drain the pus right from the abscess and they'll just leave the wound to heal itself. They'll leave it um like openly. They won't, wrap it or anything. They'll just leave it. But in complicated, you know what they do? The surgeon will pack the wound, right? Using as I told you, if they are, placing any tube or for draining purpose, if they are, closing the wound, like for example, it might be too deep abscess that they have to do an repair. Okay, so once after draining, they might have just done a repair, simple or layered closure. If that is the case, you have to code it as complicated. And if they are, using a probe, they'll break the loculations inside the abscess or cellulitis. So these are all comes under complicated IND. Okay, so these are the terms you need to look for. And when they ask you in the interview, you have to say all these things. Okay, these are very important, guys. Okay, then they might ask you what is the difference between breast tissue expander and breast implant. So tissue expander is nothing but it's a kind of an uh, implant, like empty implant that will be placed under the breast skin. So once they have done any mastectomy or anything, immediately they might place a empty implant. They will fill it with sterile water and they'll just place it so that this will help to stretch and create pocket for permanent implant. Okay. Sometimes patient comes in for a breast implant, procedure. So first to make space to, to hold a implant properly, first they will place the breast tissue expander filled with sterile water, and they will leave it there itself for 2 3 weeks, and so that it will stretch and create a pocket. Okay, on the augmentation day, on the breast augmentation day, what they will do, they will remove this breast tissue expander and they will place the permanent implant. So permanent implant is nothing but the silicone implant, which mostly cosmetic purpose they use it. Okay, silicone implants. So that is your permanent implant. Okay. Hmm. Then they might ask you what is simple and radical excision. So simple, you know what it is. They will, they'll just excise what and all is infected tissues or and all. So they will excise along with the margins. But in radical, what they will do is that they will excise the infected tissues margins, and along with that they will also take away some surrounding structure whichever is been infected. Okay, they will scrape off the surrounding structures also. So this radical excision is done during any skin cancer, or like radical, you know what it is, cancerous, right? So during that, why? Because they will take away they will excise all the lesion, its margin and the surrounding structures. For example, you can see the radical hysterectomy, radical mastectomy, right? They will take away all the lymph nodes, the muscles, correct? So that is what here also it means the same. Okay, surrounding structures will be excised. Then they will ask you what is Moss surgery. So Moss surgery, it is a technique used to define, is to remove ill-defined cancer cells. Okay, so this is one kind of technique procedure to remove cancer cells completely. Okay, so here the other point you need to add is that this physician who is going to do this thing, he acts as both pathologist and surgeon. Why? Because he will remove the tissue, he will map and divide the tissue into pieces, and each pieces will be embedded into a tissue block, individual tissue block, and it is kept under the microscope to examine. So that is why we call it as that is why we say physician act as both pathologist and surgeon. Okay, he won't require any separate pathologist. He himself will cut, map it and divide it and embed into the tissue block, and he will examine under the microscope. Okay, this is how you have to say the points. Then again, next question: radical and modified radical mastectomy. So I told you, right? Modified radical mastectomy is nothing but they will remove the whole breast tissue. Okay, they will remove the whole breast tissue. They will remove the lymph nodes, everything they'll remove. But pectoralis minor only they will remove, but they will leave the pectoralis major muscle. Okay, so pectoralis minor and pectoralis major both are chest muscles. Okay, so here in modified mastectomy, modified in the sense it is a kind of a minimal surgery. Okay, so radical mastectomy is more extensive than the modified. So here what they'll do, they will remove all the entire breast, they'll remove all the lymph nodes and also both the pectoralis muscles. So this is how you have to say for the difference between radical and modified radical mastectomy. Then they will ask you what is spinal fusion. What are the steps necessary? So they won't ask you any CPTs and all. They will just ask you what points you will search for in an OP chart. So that is what they will ask you. So you need to say that first thing we need to look for is for the approach. So approach is very important to further code the chart. Approach is very important. Why? Because we need to know whether they are anteriorly doing the fusion or posteriorly doing the fusion. Okay, or anterolateral or posterolateral. So we have CPTs accordingly. Then we need to check for the regions, whether they have done the fusion in the cervical, thoracic, or lumbar. Then we need to check for the levels, how many levels they have done the procedure, whether it is just one level, like for example from C5 to C6, or if it is of two level from C6 to T2. Okay, that is C6 to C7, C7 to T1, and T1 to T2. So this is how you check for the levels. Okay, how many levels have been involved. Then you need to check for the instrumentation, whether they have placed any instrumentation rods or plates, whether it is segmental or non-segmental. In instrumentation, we need to check whether it is anterior instrumentation or posterior instrumentation. But as we come to know the approach itself, Is I audible now? Is my voice audible?
Yes.
Yes.
Okay, fine. So whenever you're calling for the spinal arthrodesis, you need to check for all these points. Okay, so instrumentation is very important. So as I told you, it can be anterior or posterior instrumentation, but again, the the first point you need to check is whether the approach is anterior posterior. So if the approach is anterior posterior, then definitely instrument. If it is anterior, the instrumentation place will also be through anterior approach, and if it is a posterior approach, then again instrumentation can be placed through the posterior approach only. Okay, that is one thing. Then if there is any graft placed, so graft in the sense right, so autograft and allograft. So again, if it is auto or allo, we have to check whether it is morpholized or structure. So if it is morpholized, we have certain CPTs for that. If it is structural, we have certain CPTs for that. So all these are the checkpoints to code for the spinal arthrodesis. Okay. So whenever they are doing in spinal fusion, you will have all these points to check. Why? Because you will have so if the levels are like 4 to 5 levels, you'll be coding, you'll be ending up coding 2, 3, or 4 CPTs. Then, I mean, for the fusion itself, then you have to code for the instrumentation, then you have to code for the graft. So totally you might get some 9 to 10 CPTs. Okay. So it's a very high dollar procedure, and you have to do it carefully. Okay. Now coming to the arthroplasty. So they might ask you what is total shoulder arthroplasty and reverse shoulder arthroplasty. So total shoulder arthroplasty, we know that they will replace the ball and socket with prosthesis. So that is what we mean by total shoulder. But in the reverse shoulder arthroplasty, so what they will do that they will reverse the normal relationship between ball and socket. For example, in the place of ball, they will insert the socket, and in the place of the socket, they will insert the ball. So that is what they mean by reversing the normal relationship. So this is one scenario you can see, and you have the CPTs for that too, for reverse shoulder arthroplasty. Okay, that is one thing they can ask you. The other thing they will ask you what is limited debridement and what is extensive debridement in the shoulder. So in limited debridement, you need to check how many structures they have debrided. If it is just one structure they have debrided, for example, they're debriding the rotator cuff muscle, or if they're debriding the glenohumeral joint, or if they're debriding the what else? The rotator cuff. Okay, only one or two, or they are debriding rotator cuff and as well as the glenohumeral joint. Then you can code it as limited. But if it is three or more than three, then your CPT should be extensive. Okay. And one more thing I need to, tell you is that they can ask you some tricky questions in this scenario. For example, the patient might have got some rotator cuff repair, rotator cuff tear. Okay, so the surgeon will come and insert the scope into the shoulder, and he will visualize the shoulder structures. Then he come to see that his rotator cuff has been torn, the muscle has been torn, and he needs a repair. And while visualizing the other structures, he came to see that his glenohumeral joint is also kind of having some fraying, so he needs some debridement over there. So the provider is doing rotator cuff repair, debridement of rotator cuff muscle. Okay, we can say debridement of superior part of rotator cuff muscle and debridement of the glenohumeral joint. Okay, the under surface of glenohumeral joint. So here they are doing rotator cuff repair, and they are also doing debridement of the superior side of the rotator cuff and the under surface of the glenohumeral joint. So if this is the scenario, then how will you code it? Will you code it as limited debridement, or will you code it as extensive debridement along with rotator cuff? But they are doing rotator cuff repair, so you definitely need to code rotator cuff. That is the most higher dollar procedure. So you will be coding rotator cuff repair. Okay, but I'm asking here, along with rotator cuff, they are doing a debridement over here, right? Two structures they are debriding. One is in the superior part of the rotator cuff and under surface of the glenohumeral joint. So if this is the scenario, will you call it as limited or extensive? Can anyone tell me? You can think well and tell me.
Extensive.
Why it's extensive? I only told two structures debrided. Why you're telling extensive? Extensive needs three or more, right? Anyone else want to try? So here I told you, right, the patient has a rotator cuff repair and he is repairing that too. Okay, so I mean he has rotator cuff tear, so he's repairing that too. The surgeon is repairing that. And along with that, he has the provider has done some debridement on the superior part of the rotator cuff and under surface of the glenohumeral joint. So here you cannot call it as limited. Why? Because when they are debriding, they are debriding any structures. Okay, for example, now they have done rotator cuff repair, right? At the same area, if they're doing debridement, you cannot take it as structure itself. Why? Because the debridement is it is a very minute procedure, very small procedure compared to the rotator cuff repair. And also that will be inclusive, inheritant. You cannot take it as separate structure itself. Okay. They are doing a repair and they are doing a debridement. You cannot code debridement, right? You will only code the repair, correct? So here you cannot take it as limited debridement also. So this is what I want to tell you. So there is one scenarios, tricky scenarios. Procedure might be done on the same area. Debridement also is done on the same area. If that is the case, you cannot code the debridement. You cannot take that structure, debridement structure, as separate structure. Why? Because they are doing a very what to say, complicated procedure than debridement. So you will be coding for that complicated procedure. You won't code for debridement. Understood, guys? Yes, no. So this is one scenario they will ask you, like might be with an example or some chart they might ask you. Okay, so if that is the case, listen to the question properly. Okay, and if the three structures are of different areas of the shoulder, then you can take it as extensive debridement. But if the structures involves or it is inclusive to the other procedures, if they are doing a big procedure on the same structure they have debriding, then you cannot code debridement. You can only code for that big procedure. That is why I told you limited debridement is always inclusive to a big procedure of the shoulder joint. But if you're coding for extensive, you need to make sure that three structures are exclusive to each other, not inclusive. Yes, got the point, guys? So the next question is what is structure and what is morselized? So I told you, right? Structure is nothing but a large piece of bone. Morselized, these and all you can say just one word. You don't have to explain anything for this. So they might ask you like one word kind of thing. What is structural? What is morselized? So this and all you can say morselized in the sense powdered form. Structural is a piece of bone. Okay. Then next question is cardiac pacemaker and defibrillator. So as I told you, like pacemaker is nothing but they use a electrical impulse to maintain a normal heart rate. For example, for if the patient is having bradycardia, for bradycardia patients, they insert pacemaker. But for tachycardia patients who is having fast arrhythmias, who is having life-threatening, tachycardias, those patients they insert ICD. Okay, it's nothing but cardiovertebral defibrillator. Okay, ICD, we call it as ICD. It's nothing but defibrillator only. Okay, inverted cardioverter defibrillate. Okay, so they just ask you what is pacemaker and defibrillator. What is the difference? So difference you can say pacemaker is inserted for patients who is having slow heart rate or bradycardia, and defibrillator is placed in patients who's having increased heart rate or high heart rate who's having tachycardia. Okay, now colonoscopy. So colonoscopy, that decision tree is very important, guys. So if the scope reaches to cecum, we will consider as colonoscopy. If it does not reach splenic flexure, we consider as sigmoidoscopy. If scope reaches hepatic flexure, okay, but not to the cecum, then we can call it as colonoscopy, but we need to append 52 or 53 modifier accordingly. So if it is therapeutic, for therapeutic, what ICD will you, what modifier will you append, guys, for therapeutic?
52 modif.
Guys, you guys, mm, what about others?
52 and 53.
I'm asking when will you quote 52, when will you quote 53?
52 for therapeutic colonoscopy and 53 for diagnostic colonoscopy.
Yeah. So whenever that is very important. You need to check if they just come for diagnostic purpose or they are doing any treatment. Okay. And if the scope doesn't reach the hepatic, I mean, it reaches the hepatic flexure, but if it doesn't reach the cecum, then we need to append these modifiers with the CPT. We can call it as colonoscopy, but with the modifier. Okay. Now, again, one thing is that if the payer is Medicare, I told you, right, you can use PT modifier. And if the payer is non-Medicare, we have to use 33 modifier. So these are like the Medicare modifiers. Okay. So it's kind of a billing modifier. It is a a rule guideline for Medicare payers. You need to code it. Okay. So that is one thing. So EGD we know, right? EGD is a scope, esophagogastroduodenoscopy. EGD can be considered only when if the scope reaches till the second part of duodenum. If it doesn't reach second part of it, if it just gets stopped somewhere in the end part of esophagus, we'll call it as esophagoscopy. But if it is inside the first part of duodenum, then we call it as EGD. Okay, till second part we can call it as EGD. If it crosses the second part, if it goes to third part, and if it goes to the ileum jejunum, you have to code it as what you have to code it as. Tell me. Enteroscopy. Okay, intestinal endoscopy, small intestine endoscopy or enteroscopy. Okay, so scope where it is getting inserted is very important in coding esophagoscopy, EGD, and enteroscopy. All the three scopies are the same. Okay, we saw the biopsy, we saw diagnostic CPT, we saw the submucosal injection, right? We saw the polypectomy, removal of polyp snare technique, hot biopsy, and all those things. So it the the all the definitions are the same. The only thing you need to make sure is whether the scope is placed in the esophagus or is it in the the within the second part of duodenum or beyond that. If you find out that first, then your coding part is easy. Then you can see what procedure they have done. Accordingly, you can code. Okay. Then they might ask you what is like definitions. They might ask you what is Hartmann procedure. So Hartmann procedure is nothing but they remove the infected part of bowel and redirect the main, the other part, remaining part to a colostomy. Colostomy is nothing but it's an artificial opening towards the outside of the world, outside of the body. Okay. So they will just cut down the large ball if the patient has or is or has cancer, okay, large intestine cancer, and the large intestine is like it's in a condition where they have to resect it out, and they might resect that part of the large bowel, okay, and they will redirect the other part into the colostomy. They will just make an opening in the abdomen, okay, and connect that remaining part to the outside of the abdomen, so that whatever they eat, the waste materials will come outside that stoma. Okay, so that stoma becomes their anus. Okay, so that is what we mean by Hartmann procedure. Then we have hernia types. So you know what you have to say when they ask what is hernia. Okay, and you have to explain the types: hiatal, umbilical, inguinal, femoral, incisional, ventral. So all these are the types of hernia. And most importantly, they will ask you what is incarcerated, what is strangulated hernia. Why? Because most of the hernia charts, the coders, they miss to code for incarcerated and strangulated. We have separate ICDs for that and separate CPTs for that, right? So that is very important to know. So incarcerated is nothing but tissue gets trapped inside the hernial sac and it cannot be pushed back to its normal position. Strangulated in the sense it is a kind of a complication where this trapped tissue's blood supply is cut off, and what happens? That trapped, which is with the tissue which is trapped inside, will die, which in directly causes um, a life-threatening what to say circumstance. Why? Because this complication can lead to sepsis also. Okay, the hernia can rupture, it can spill off. Okay, so before it gets strangulated, it has to be taken out. Okay, then we know I told you about TURB, right? Transurethral resection of bladder. So whenever you're coding for transurethral resection of bladder, you need to check for the size of the bladder tumor. That is very important. Whether it is a small, medium, large. Okay, so that is very important in order to code for transurethral resection of bladder. Then they'll ask you what is nephrolithiasis. So I can say nephrolithiasis is nothing but stones just found in the kidney or renal pelvis. Okay. Now they might ask you what are the treatments to remove the kidney stones. So then you can say lithotripsy. Okay, so lithotripsy can be extracorporeal shockwave lithotripsy or laser lithotripsy. So in extracorporeal shockwave lithotripsy, they use some external sounds and waves to break up the stones, okay, to remove the kidney stones. But in laser lithotripsy, they will use some laser to to fragment the stones, okay, so that it can pass by its own through the urine, okay, or they might basket it. They will use a small loop kind of wire, and they will try to remove the fragmented stones. Okay, so this is what you need to explain. They ask lithotripsy. Then they can ask you what is the difference between vaginal and um, abdominal hysterectomy. So that is very important. So this question is very important, guys, because most of the interviews they are asking this question. Okay, so vaginal and abdominal hysterectomy. So we know through vagina, if they remove the uterus and the fallopian tubes, we call it as vaginal hysterectomy. And abdominal, they'll just make a large incision on the abdomen and they will remove the uterus. Okay, so there are some pros and cons. Actually, in vaginal hysterectomy, the procedure itself is very less, less invasive, and patient has a very faster recovery, and there is no incision made. Okay, no pain. I mean, not no pain, less pain. Okay, so within 1 or 2 weeks, the patient will be back to work. But in abdominal hysterectomy, it's a kind of a cesarean section, right? And there will be a very large incision on the abdomen. Okay, and they have to take rest for like almost 2 to 3 months, like how they need rest for cesarean section. Likewise, okay. Now, most of the providers they will advise for abdominal hysterectomy if the patient has some complexity such as large fibroids or cancer. Okay, or if the patient's pelvis is too small. So in all these conditions, they will suggest for abdominal hysterectomy. But vaginal hysterectomy is less invasive than abdominal hysterectomy. Okay. So this is how you need to explain if they ask you what is the difference between vaginal and abdominal hysterectomy. Then they will ask what is cataract. Okay, what is goniotomy? So goniotomy is nothing but it's a treatment to treat the glaucoma. Okay, so it will reduce the pressure in the eyes and so that it prevents the vision loss. Okay, so they might ask you what is cataract, goniotomy, blepharoplasty. So blepharoplasty, I told you, right, is a cosmetic procedure. They will just resect the excessive skin or excessive fat in the eyelids. Okay, so that is what they do in blepharoplasty. So then next thing you need to see is that they might ask you about the NCCI edit. So NCCI edit stands for, I think most of you guys know what is NCCI edit. So NCCI edit stands for National Correct Coding Initiative. So this is being followed in all the coding companies and all the CMS and all the coding. This is a kind of a general thing we need to follow to prevent any improper payment. Okay, to prevent fraud, abuse. Okay, to prevent all these scenarios, we need to code the inside. So whenever you're coding for 3 to 4 procedures, always check. Always, check for the edit. If there is any edit, if there is no edit, then well and good. But if there is any edit, and if it needs a modifier to bypass it, then please append the modifier. If the codes cannot be coded together, then don't code it. Okay, so we need to understand the three indicators. So we have three indicators: 0, 1, and 9. So 0 means if the indicator shows 0, then it is that we need to understand that those two CPTs cannot code together. So for example, we will have to enter one CPT in the column 1 and the next CPT in the column 2. We need to check if these two CPTs can be coded together or not, right? Also, we need to check for the MUE unit, right? Medically unlikely edit. So all these They will ask you what is MU. This is also one kind of interview question. Um, okay, so yeah. So if these two column one and column two, if the column two is showing 0, it means that you cannot code that column two CPT with column one. And if it shows 1, then definitely you can code it, but you need to use an modifier. It can be laterality modifier, or it can be like 59 modifier, anything to bypass the edit. Now, if it shows 9, it means that there is no modifier needed. You can code those two CPTs together. It goes well with each other. Okay, so that is how you have to understand. But NCC edit is very important, guys. You cannot code any procedures without NCC edit. Why? Because there might be denials, there might be payment issues. Okay. The next thing we will ask you what is a modifier. So modifiers, they'll ask you what is 73 and 74. Okay, so you should say what is 73. So 73 is nothing but they will discontinue service before any anesthesia has been given to the patient. Okay, and 74 is nothing but the procedures they will be discontinued. What are the procedures will be discontinued, but this will happen after anesthesia has been given to the uh, person, to the patient. Okay, now um, I'll just move on to next modifier and tell you what is the difference. Okay, now they might ask you what is 52 and 53. So 52 is nothing but reduced services. Okay, so if there is any procedure which has been reduced, it has not been fully completed, so we call it as reduced procedure. So in that case we can happen 52. 53 is again for discontinued services. So this there is a difference between 53. They will ask you what is 53 and 74. They might ask you what is the difference between 53 and 73. So it is nothing but the main difference is that 53 modifier is used in physician coding for professional coding. When you code for the physician, you will use 53. If the service is discontinued, you cannot use 74 or 73. But if you're coding for facility, that is hospital, and if there is any procedure which has been discontinued after anesthesia, you can code 74. And if it is discontinued before anesthesia, you can code 73. Yes, guys, so these are the differences they might ask you. Okay, so I will be sending you this materials to to the group. Okay, do you have any questions, anything to ask me?
Can you repeat the NC edit please?
Okay. So NCC edit is nothing but to prevent improper payment. If you are coding a chart and if it has lot of procedures to code for, and it might have 3 to 4 procedures. Okay, just give me a minute, guys. Just give me a minute. Yeah. Sorry, I got a call. That's why. So yeah, what was I telling you? Yeah, so if a chart has like 2 to 3 procedures, okay, and you need to code it, you have found all the CPTs. But before moving on, like further processing the chart, you need to put those 3 CPTs into the encoder, or you have encoder pro, or you have codify. You need to put these 3 CPTs, okay, and check for the edit. Okay, so sometimes those 3 CPTs might go together to go well with each other. Sometimes one procedure might be inclusive to the other procedure. So in that case, you cannot code the other procedure which is inclusive, right? You can only code one procedure, which can which actually covers all the other procedures. You can code that. But if there is another CPT which is inclusive to the primary CPT, you can only code for primary CPT. You cannot code for the other CPT. So that is why we always tell you to check for the NCC edit. Okay, but if there is a need of coding the second CPT. Why? Because the anatomy might be different. In that case, you can append modifier 59 and code both of the CPT together. Okay, so we have three indicators 0, 1, and 9. So if it shows 0, it means that you cannot code that two CPTs together. Okay, you cannot. It is a big error if you code both CPTs together if it shows in 0 indicator. But if it shows 1, it means that you can use some appropriate modifier to bypass the edit. For example, XU modifier or 59 modifier or any laterality, right or left. Okay. Then if it shows 9, it means that you can code both CPTs together. There is no problem. You don't need any modifier to bypass or anything. You can, you know, be confident to code those two CPTs together. So this is what any NCC edit is for, to prevent improper payment. Okay. So if you don't follow NCC edit while coding, it can lead you to errors, blunders. Okay. And it might not go for I mean, the claim which you are processing won't go it as for clean claim. It will come back, it will bounce, it will come back after a denials. Okay, so all these things can happen. To prevent all these things, we need to follow NCC edit. You're clear, Teju?
Yeah, yes, ma'am.
Guys, any other questions you have? Vrishali, Swapna, Kiran, Badusha, Sangeeta, Nikhil, Swati, Divya, Bhuvaneshwari, Sheikh. Yes, Nikhil, we're talking some. Yeah, tell me, Nikhil. Yes. So, yeah, 80 is for assist. 81, 80, 81, 82, and AS modifier is for assistant surgeons. And we also have GC for resident. I think GC you guys are familiar with. So 80 is for, assistant surgeon. And if the assistant surgeon is an MD, okay? So if it's an MD, he's a physician, you can append 80 modifier. Okay. And 81, to check that, I forgot. 81.
For minimal assistant surgeon, limited assistance.
Right. Thank you. So, yeah, for example, if a patient comes in, okay, he's admitted and all. So the primary surgeon is doing some, he's the main surgeon and he's doing the procedure, and he needed someone to just assist him for a minimal time, right? So that the other physician, he's an MD, he'll come, he'll just identify what is necessary to be done. He will do that part of procedure and he'll go back. He won't stay there for an entire procedure. Okay, so that is the case, then you can use 81. But 82 is used when a qualified resident is not available. This happens in a teaching facility. For example, um, um, you have seen hospitals with medical college, right? So we call it as teaching facility. They will have medical college, they will have their residents, their interns to work in the same hospital, right? So one college might have its own medical hospital and college. So we call it as teaching facility. Why? Because in hospital, what they do, they will use the interns, okay, and with the help of a physician, they will assist. Okay, so here, if in a training facility, the first approach what they will do if they need assistant surgery is that they will try to approach a qualified resident. If that qualified resident is not available, that means that if that qualified resident is not available, they will call a medical doctor. He can be an MD or a surgeon, whatever. Okay, because of the absence of qualified resident, they will call a doctor. Okay, so this happens in the teaching facility. If that is the case, then you can append 82 modifier. Okay, so 80, 81, 82, you cannot see in same day surgery. You can only see this in the general surgery. If you are entering into a general surgery project, you will see 80, 81, 82, AS modifier, all these. In same day surgery, we never use 80, 81, 82. Okay, and we also have another modifier AS. So AS is used when the assistant surgeon is a PA or a NP or any clinical nurse specialist, CNS we call it as, or registered nurse first assistant, RFNA. Okay, so if these eligible persons have been come and they're assisting, in that case you can append AS modifier. But again, guys, I'll tell you, chumma you cannot append. You need proper documentation. Chumma in the sense simply, okay? Simply you cannot append all these modifiers because it needs a proper documentation. They have to give an attestation that um, so and so has been present with me or has been scrubbed with me for the entire procedure. In that case, you can append 80. And for appending 82, they should mention that the resident surgeon or the resident was not available during that time, so we used this particular doctor. So in that case, you can append 82. And AS, for to append AS, they should attest like uh, this person was very important for this particular part of the procedure, and so he was present there for the entire procedure. If this is the attestation, then you can append AS modifier. So appending assistant surgeons, you always need um, a documentation attestation from the primary surgeon. If there is no attestation from the primary surgeon, you cannot bill for the assistant surgeon. Okay, guys. Anything else? Vrishali, Sangeeta, Badusha, Teju, Divya, Swati,
Sonia,
No, sorry.
I have one question.
Jake. Yeah, tell me.
In colonoscopy cases, we should follow 52 and 53 modifier by default by the physician tree, or we have any guideline regarding that?
Guideline is nothing, Sheikh. What I told you is the guideline. That is what we call it as colonoscopy decision tree. So if they are using it in a therapeutic manner, you can use 52. See, again, I'll tell you, this thing is for interview purpose, Sheikh.
Okay.
Okay. Uh, See, what we study is totally different. What we do is totally different, right? Are you guys agree on this?
Yes, Sonia.
Yeah. So whenever you code, whenever you start coding for surgery, you'll be like thinking, array, what we studied was different, right? So for the interview purpose, when they ask you about the colonoscopy surgery, the colonoscopy decision tree, you can say this, whatever I told you. If the scope doesn't reach the cecum, you have to, call it as colonoscopy. If the scope doesn't reach the splenic flexure, you can call it as sigmoidoscopy. And if it is therapeutic, we will append 52 modifier. If it is diagnostic, we append 53 modifier. Right? So this is how you have to. But while you're coding, practically, I'm telling you, it is based upon the payer. For coding purpose, I'm telling you, it is based upon the payer. Whenever you get a colonoscopy, it is very easy. Okay, that is first point. But whenever you're coding for a colonoscopy, the first thing you will be checking for as a surgery coder is the payer, whether it is Medicare or non-Medicare. Then next thing you need to check for is whether they have come for screening. Okay. If it is screening, you need to check whether it is high risk or low risk. So if it is high risk, you have G0105. If it is low risk, you have G0121. So this is for Medicare purpose. This is worldwide guideline, Sheikh. Okay. So wherever, whichever company you work in, for Medicare, they have their own set of guidelines you need to follow. Then only it will get billed. Okay.
Okay, sir.
It depends. Like some company they might train you again. Again, they will teach you from 1 to 6 series and everything. And client specifically they'll teach you. So this is like what I am teaching is general guidelines for surgery. Once you enter into a company, they will teach you client specific guidelines. So in that case, you have to forget the general guidelines and stick to client specific because again, we work for people, for money, right? So they have their own client will have their own specifications, their own, like sometimes what they follow is against the general guidelines. So again, you also need to follow the same. Why? Because you'll be coding for the client, right? That is one thing. So if they are teaching you again, you can, learn, and it won't like take too much of time, Nikhil. Okay. So once you start coding, you'll get to know. And it's probably like, I would say like 5 to 6 months. See, you guys might have, like, I don't know, you guys might have worked in facility for so many years. And if you're like going and, joining a new facility, it takes time, right? To settle down. Minimum 6 months. Obviously, you need to learn a lot. Surgery is not like ENM or, you need to learn, right? Like I told you, they might teach you about the specific guidelines, like client specific and all. So you have to adhere to it, right? There are a lot of things you need to write down. Every day you need to keep learning, Nikhil. It's not that just you learned and, no. Every day you need to keep learning so that it, stays fresh in your mind, right? So it takes time. So I'm just giving you that um, like maximum, 5 to 6 months. That's all. And if you're a very confident person, you're a very pro, you're like, fastly grasp everything, then it might only take 2 to 3 months. It depends upon you, Nikhil. Hmm. What else? Swapna, Divya, you guys can speak. I haven't heard Swapna speaking. Divya also I've heard speaking, but Swapna, rare. Is there anything else you guys want to ask? Yeah, who is this? Swapna.
Swapna, ma'am.
Yeah, yeah. Hi, Swapna.
Ma'am,
Anything you want to
how we
ask?
have to update our resume, ma'am,
Yeah.
regarding
So,
this surgery?
yeah, that is one thing I need to tell you guys. You cannot, put it as that you don't know surgery. No. So you need to at least, edit it as like you are into surgery for like 8 to 9 months, something like that. You can put why because you know certain things right now. So for cracking the interview, you know what to say and what not to, right? So for that purpose, you need to like just edit your resume, make it as like you have an experience of 8 to 9 months in surgery, in same day surgery. Okay, put it as same day surgery. You can use project names such as partners, okay, or Baylor. All these are kind of project names. Okay, if they won't ask you project name, but I'm just telling you. Okay. So you can put it as 8 to 9 months just to show that yes, you have worked in surgery. Okay. And also, I request you all to give your mail ID details to Suchitra. She has messaged right in the group to get the certification. They'll send you the certificate that you have completed the cross training. So you can send the details. You need to give the name, mail ID. Okay. You can put it in the group itself, tagging Suji. Like she can tag Suchitra and put your name and mail ID so that they can send you the certification. So, as I told you guys, everyone, you can just put like you have an experience like 6 to 7 or 8 to 9, like accordingly, not more than one. Don't put not more than. You can, it's not an issue. You can also put it as 1 year. No one is asking you about that. The only thing is that you need to know and you have to be confident enough to attend the interviews. Okay. And if there is any, wait a second, Teju, let me explain. If there is any before interviews in some companies, they will they will give you a written test. Okay, if that is the case, you can just message me. I can help you out to crack the written test. Okay. Yes, Teju, tell me.
Ma'am, demo charts is not available on for
Demo
just
charts I don't have.
other. Initially, they
Yeah.
said that will be some
Can you
money.
ask with Fazil?
Yeah, sure.
Yeah. Okay. Demo charts which I showed you, that's all. Not more than that. I can't show you live charts, right? How it's like against HIPAA complaint. I can't do that. Demo charts,
Yeah,
if you want more, I can send you. That's
yeah,
what
okay.
I mean by demo charts. I can't send you live charts. No one can send. Why? Because it is against, we cannot take it from the system, right? We don't have access. And you cannot do it. It against HIPAA. In which chapter you want demo? I
Not
mean
like that,
the
ma'am.
charts.
Just not like that. We just have to just have knowledge regarding how to process the chat
Okay.
because we are not
Okay, I'll
aware
send
of
you
that.
some. You want to know the format of the
Just
OP chart, huh?
uh, something related to charts, ma'am. That uh, formats will be different in HCC type coding and also in HCC type.
I got it. I got
And
it. You
also
need to know the formats.
checkpoints of the
Checkpoints, I told
particular,
everything.
like not
I
related
told
to the
all.
coding one. For some
Then
providers like that, like
no,
that.
no, no. We don't
Is there
have
any other
checkpoints for providers and all. No, 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 no. That
question?
totally depends upon the client you're working. See, I can only teach you general guidelines. So once you get
Yeah,
into
okay.
the the project, then you'll get the checkpoints like what which provider and all you will get. Now I can't say any providers and all. No, how do I know? There are a lot of
Yeah, okay.
providers. Anything else, guys? Vrishali, Bhuvneshwari, Divya, Swati, Sangeeta, Kiran.
Sonia, this is our last class.
Sorry, yeah, yeah. This is the last day.
Okay, Sonia.
For that, for that you unmuted and asked me. Huh? I thought you were going to ask me some doubt. Anything else, guys,
No
you want to
doubts.
ask me before winding up? Because we won't be connecting from tomorrow. So yes, probably this is the last day. So if there is anything, I'll send you the, if there is any what to say, scopes and all. If there is, if I get any ads regarding surgery coding and everything, I'll be sending. We three will be sending all those, forwarding those to your group, so you can stay active in that. And as like, if you guys are, you can start what to say, start attending the interviews. So my suggestion is that first start from a very small companies. Why? Because I'm telling you is that once, like, at first itself, don't go get into R1 RCM, or attend their interviews, or don't get into big healthcare companies and attend the interviews. No, start from the small, so that even if you don't go through the interviews, at least you'll get an experience, that what they ask and what they not, and what are the questions, you can just mark it, and you can prepare well for the second interview. Okay, so that is how you can build your confidence, right? So some of you guys are very confident. I know, like, you guys can at one go you can crack the interview. That is well and good, but I'm just saying, like, um first itself, don't focus on a very big company, like, I know you everyone wants to get into a big company, that I know, but just a suggestion, like, before focusing on your company, big, your lucky company or whatever, before that, try to attend some interviews, and so that you get experienced. It's a kind of a mock interviews, and you'll get prepared well, right? After that, you can attend the interview, or to the company which you want to, so that you can easily get into. Okay, so try to, even if you feel doesn't matter, so that it remains fresh in your mind. Okay, so never stop learning. Okay, there are a lot of things to learn, and surgery is very large. Okay, it's from seven, sorry, one series to six series. It is a very huge part of CPT coding.